Good afternoon, everyone. Thank you, chairpersons, for that kind introduction, and thank you, Ganesh sir and the team for having me here. So my job is to discuss approach to newly diagnosed diabetes in young. So it will be a case-based approach. So first, how do we define diabetes in young? The definition is very arbitrary. It has varied across time periods, across the studies or registries and the reasons. Earlier definitions, older classifications would use age at onset of less than 30 to 35 years, but we have a large ICMR-funded registry going on in our country, which takes age as less than 25 years as a young onset diabetes. This registry is called as YDR registry, and then we have a search registry in US, which takes a cutoff of 20 years to define young diabetes. Now, why should we talk about young diabetes, or why should we classify it separately? The reasons are manifold. One is that while in adult onset diabetes, the predominant chunk is from type 2 diabetes, it's not the same case in young diabetes where there could be a spectrum of diagnosis. These individuals develop hyperglycemia at an early stage, so at a given age, they have a higher cumulative burden of complications, and especially when they are most economically productive, so it leads to a lot of loss of life years. And for a given type of diabetes, such as type 2 diabetes, you can see differential behavior between young and adult onset type 2 diabetes. And that's why we should talk about it separately. Some data from the YDR registry that I talked about, the first phase of this YDR registry clearly shows us that about 90% of all cases of young diabetes are type 1 and type 2. Type 1 still remains the most common, about 60 to 65%, but type 2 is fast catching up, especially in private clinics and in urban cities where it comprises of about 25% of all cases of young diabetes. And this is a registry which runs across India, comprised of 205 reporting centers and 8 regional collaborating centers, with AIIMS Delhi working as a technical collaborating unit for this registry. And what is also interesting, insights that come out from this registry is that if you develop diabetes at less than 10 years, that is at a pre-pubertal age, it is almost always type 1 diabetes, and type 2 is very, very unusual out here. But if you move from 11 to 20, the chunk of type 2 starts increasing, especially after puberty, after 14 to 15 years. And above 20, between 20 to 25, type 2 possibly overtakes type 1 as the most important differential diagnosis. And this is something we should keep in mind when we discuss all the cases. So this is a brief, we have read it many a times, the differentiation between type 1, type 2, MODY. But what is one important point that I wanted to emphasize is that when the background prevalence of BMI, increasing BMI or overweight, obesity is increasing, so we can't say that all type 1s will be lean. They would not have features of insulin resistance. So you can have background obesity with type 1 diabetes. So that would not be a very useful discriminatory feature in the today's era. Age at onset we have discussed. Autoantibodies, again, there are caveats to autoantibodies. While you expect autoantibodies to be positive in type 1s, in Indian setup, we see a lot of autoantibody negative or idiopathic type 1 diabetes. Some data I will show. C-peptide has its own limitations, especially in the early years of type 1 diabetes, where it can be very non-discriminatory, and a strong family history, especially in one parent and multi-generation supports MODY, while in both parents supports a diagnosis of type 2 diabetes. So with this, I will move to some cases, and then we will discuss each case separately. So this patient is a 7-year-old girl who comes to emergency with osmotic symptoms, rapid breathing, altered sensorium for 1 day, and she has rapid shallow breathing with fruity odor, and she has features of metabolic acidosis, which is high anion gap. She has elevated blood ketones, and she has hyperglycemia. She has no family history of diabetes. This is a severe diabetic ketoacidosis, and there is no doubt in our mind she has presented as at prepubertal age with an index presentation of severe decay, which you can see in 25 to 30% of type 1 diabetes cases. Obviously, you manage with IV fluids, IV insulin infusion, later shift the patient to subcutaneous insulin, and provide a comprehensive diabetes education. The question is whether you would measure islet autoantibodies in this case. In clinical practice, this is not needed because this case is a typical clinical type 1 diabetes in presence of the kind of history that we have seen, the age at presentation, and the presentation with spontaneous decay episode. So if it can be done, it can be done, but it is not absolutely necessary. C-peptide, I will discuss, it should not be done within 2 weeks of an acute hyperglycemic emergency because it can be falsely low, and then it will have its limitations in the initial years of diagnosis. Obviously, because it's an autoimmune disease, it's important to look for celiac disease and thyroid dysfunction simultaneously. So some data about islet autoantibodies in type 1 diabetes, and this was data we collected at AIIMS New Delhi, where we looked at 366 participants with clinical type 1 diabetes and looked at islet autoantibodies and their C-peptide trajectories. And what we found was that at a median duration of 6 years, only 67% of patients tested positive for one of the islet autoantibodies, that is IA2, ZNT8, and GAD65. And obviously, GAD65 was the most predominant autoantibody. And when we looked at a diabetes duration of less than 2 years, this increased to about 76%. So which means that even in recently diagnosed type 1 diabetes, which is clinical in definition, you can get 1 in every 4 who are autoantibody negative. And this data is also reflected from SGPGI Lucknow, where authors have reported that for 4 autoantibodies, positivity is only around 70%. So in Asian context, unlike Caucasians, we may not have autoantibody positivity in all cases. So if it is autoantibody positive, it supports a diagnosis of type 1 diabetes, but if it is negative, it does not exclude the diagnosis of type 1 diabetes. Just a point about C-peptide. C-peptide has low discriminatory value in the initial years of type 1 diabetes, and as you can see from this data, in the first 5 years of type 1 diabetes diagnosis, up to 50% of adults and up to 33% of adolescents can have a stimulated C-peptide of more than 0.6 nanograms per ml, which is the cutoff we take for absolute insulin deficiency. And that is why the discriminatory value is not higher in the initial years after the diagnosis of type 1 diabetes. So we use a simple classification. This is derived from a review paper in diabetic medicine. And in our clinical practice, I prefer to use fasting C-peptide because it's easy to perform and there is more standardization for the test. So if the patient has a fasting C-peptide of less than 0.24, then it suggests an absolute insulin deficiency and patient requires a basal bolus insulin therapy. If the levels are between 0.24 and 0.75, it suggests that patient has relative insulin deficiency, requires insulin therapy at least alongside some oral drugs. But if the levels are more than 1.2 nanograms per ml, even at the onset of diabetes, that would make type 1 diabetes very, very unlikely. And that would suggest that there is significant beta cell reserve that is present and that would support a diagnosis of either type 2 or a MODY. Now coming to the second scenario, a 20-year-old male who was diagnosed to have diabetes 4 years back with weight loss and osmotic symptoms, started on alternative treatment, then shifted to oral drugs, but he remained poorly controlled and he was insulin naive, had family history of diabetes in both parents, hypertension in father, there was no history of smoking or alcohol use, and on examination we see that he is obese and he also has central obesity in form of waist circumference by South Asian criteria, and he has grade 2 acanthosis nigricans. Now the patient presented to us in October 2024, and at that time he was already using 3 oral drugs. He had a very high HbA1c, had dyslipidemia in form of elevated LDL cholesterol and elevated triglycerides, and had elevated albumin creatinine ratio. Now at this point in time, we shifted the patient to DAPA SGLT2 inhibitor alongside DPP4 inhibitors and metformin, and HbA1c came down to 7.7, meaning he required 4 drugs, and subsequently we shifted him to 5 drugs, and at cost of using 5 drugs, we could manage a HbA1c of 6.3%. So this slide shows that there is an accelerated beta cell decline in a patient with young onset type 2 diabetes. You have to use upfront multiple therapies. This would show that this is a more aggressive form of diabetes. And one other thing that we note out here is that at such a young age, patient has already developed albuminuria and has dyslipidemia. That means the CV risk factors are also accumulating at a very rapid pace. And that is why young onset type 2 diabetes is very different from adult onset type 2 diabetes. So it's very clear that this patient has young onset type 2 diabetes. He has a very good C-peptide response. Fasting C-peptide was 1.5, has dyslipidemia, moderately increased albuminuria, and patient seems to show features of accelerated beta cell dysfunction and vascular complications. And this is some data from the 2-day trial which shows that young onset type 2 diabetes, adolescents with type 2 diabetes have a faster decline in beta cell function. They tend to fail metformin therapy or metformin plus lifestyle intervention therapy more often. About 50% cases at a follow-up of 3.5 years had a failure rate of metformin or metformin plus lifestyle intervention therapy. And if we compare the data from this study with adult type 2 diabetes studies, we can say that the failure rates are higher and the beta cell decline is faster, which indicates that there is more aggressive trajectory of beta cell decline in patients with young onset type 2 diabetes. Also, if we look at the data, these are the individuals who were just 8 months into their diabetes diagnosis, and we can see that they have so many cardiovascular risk factors already accumulating in form of elevated blood pressure, microalbuminuria, low HDL cholesterol, and elevated triglycerides, and that would take a toll on their cardiovascular risk in the long run. And not only the CV risk factors, but that there is data emerging from the search registry in US which shows that at a given age, the prevalence of various microvascular complications is also higher in young onset type 2 diabetes compared to type 1 diabetes. So type 2 diabetes in young age is possibly even more aggressive than a young onset type 1 diabetes, and this is what is being shown, that they have higher prevalence of diabetic kidney disease, retinopathy, peripheral neuropathy, and hypertension or arterial stiffness. So this is a review that recently came up in Lancet, and this talks about the various aspects of management of early onset type 2 diabetes, and that would include aggressive glycemic control, CV risk reduction, weight management, aggressive complication management, and good reproductive care. And that is important because unlike adult onset type 2 diabetes, where the women have already they have already completed their family, this aspect of young onset type 2 diabetes also affects them in their peak of their reproductive age group. So it's important to discuss the preconceptional care, optimization of preconceptional care when they are pregnant, multidisciplinary care, and the postpartum state. Important to understand what are the implications of each pregnancy can have on glycemic control as well as on vascular complications. In terms of management, the options for managing adolescent type 2 diabetes are more limited as compared to older adults. So in adolescents with type 2 diabetes, earlier we had only 2 agents, those were metformin and insulin, but now we have data from ELLIPS trial, Dynamo trials, which have led to approval of even GLP-1 RAs and SGLT2 inhibitors. But in individuals who are less than 18 years, sulfonylurea and DPP-4 inhibitors are not approved for management of young onset type 2 diabetes. But if you have individuals above 19 years, you can manage them like any adult with type 2 diabetes. Moving on to case number 3, this is a 19-year-old male who were referred for hyperglycemia evaluation, had recurrent episodes of epigastric pain since last 10 years, some of them even requiring hospitalization, IV analgesics, and we see that he has clear hyperglycemia, but ketosis is negative, and he is having a catabolic state. And on X-ray, we can make out calcification in the region of pancreas onto the L2 vertebrae. You can see onto the left of the L2 vertebrae, and overlying the spine, you can see ductal calculi, which are coarse. And this is also confirmed on the ultrasonography. Fecal elastase was low, which suggests exocrine insufficiency, but patient did not have hypercalcemia or hypertriglyceridemia to explain the alternative causes. And this comes out to be as a type 3C diabetes because this was placed in the section 3C of the ADA classification. And amongst various forms of type 3C diabetes, this is a fibrocalcific pancreatic diabetes that is unique to tropical countries, and a classification has been proposed by Dr. Mohan's group, where if you see a patient who is a resident of tropical country, has diabetes, has pancreatic calculi on abdominal X-ray, and you rule out alternative causes such as alcohol, gallstones, or hypercalcemia. These are individuals with fibrocalcific pancreatic diabetes. They require nutritional rehabilitation, enzyme supplementation. They require insulin therapy in most cases, can be controlled with sulfonylureas in the initial stages, and they have very challenging glycemic variability, and the reasons are multifold. One of them is glucagon deficiency, other is inadequate pancreatic enzyme supplementation leading to nutrient malabsorption. Moving on to case number 4. So this is a 14-year-old female which we saw. She came from a rural area of Madhya Pradesh. She had very low socioeconomic status. She had diabetes for last 2 years. She took insulin just for 2 weeks, and then she shifted to herbal treatment. But despite not taking insulin for such a long period of time, she did not develop any ketoacidosis. She just had osmotic symptoms, excessive fatigue, for which she had to leave the school. She had progressive blurring of vision, and you can make out on the photograph that she has bilateral dense cataract, which prompted her to come to us. Otherwise, she would not have even sought medical attention. She had signs of protein energy malnutrition, had a BMI of 13, and bilateral dense cataract with the PL plus visual acuity. And on evaluation, we see that she had very high glucose, but she's ketosis resistant. She does not have any pancreatic calcification. She had transaminitis, which resolved with insulin infusion, and she had very low fasting C-peptide levels. She's autoantibody negative, and she has hypothalamic dysfunction because of hyperglycemia. So young onset diabetes, lean type, very lean in fact, insulin requiring, but she's not dependent on insulin for survival, unlike a patient with type 1 diabetes. She has an insulin secretory defect. She's negative for the autoantibodies. Her pancreatic structure is normal. Body fat analysis was not done, and NGS was also not done in this patient to rule out MODY, but the likely diagnosis remains what was described previously by Dr. Tripathi, Dr. Ahuja as KRDY or malnutrition-related diabetes, and what is now being rechristened as type 5 diabetes from some pioneering work that's being done in CMC Vellore. So these patients have isolated defects in insulin secretion. They are managed with nutritional rehabilitation, insulin. And in this patient, after we gave insulin infusion followed by MSIS, she gained 4.5 kgs of weight over 5 weeks of admission, and she's next planned for a bilateral cataract surgery. Last case, just to highlight that we can get spectrum of disorders in young diabetes. So she's a 30-year-old pregnant female who came to us with a history of hypertension, which was diagnosed in last pregnancy, and that led to fetal demise. And she was referred in view of OGTT, which showed overt diabetes in pregnancy. As we can see, 2-hour glucose is more than 200. She had typical red-colored striae, ecchymosis, thin skin. And on evaluation, although evaluation of Cushing's in pregnancy is quite difficult, but we can see that she has clear loss of circadian rhythm, and she has elevated DHEAs and a suggestion of ACTH-dependent Cushing's. Her lowest serum potassium was 3.2. We managed her. I will not go into details of how we managed her, but after surgical intervention, as we can see, her insulin requirements dropped. She was very well managed during the pregnancy. She delivered a healthy baby boy. Her blood pressure normalized, and she did quite well. And now she's in our follow-up, and you can see there is quite a lot of change in the kind of fat deposition that she has had. So the key points that come out of this presentation is that there is a spectrum of diagnosis that you can expect in the broad umbrella of young onset diabetes. In young onset diabetes, you expect more symptomatic presentation as compared to adult diabetes. There are multiple reasons. One is that type 1 diabetes is the most common cause of young diabetes, and most often type 1 diabetes has acute symptomatic hyperglycemia as opposed to type 2 in adults, which is more incidental. If you get spontaneous ketosis and diabetic ketoacidosis, that favors the diagnosis of type 1 diabetes. Prepubertal presentation is highly unusual, as presentation at less than 10 years is very unusual in type 2 diabetes. C-peptide response is most useful beyond 3 to 5 years. If you get a preserved C-peptide of more than 0.25 nanograms per ml beyond 3 to 5 years of diagnosis of diabetes, that makes type 1 diabetes very unlikely, because you would expect absolute insulin deficiency in type 1 diabetes. Islet autoantibodies, which we so highly rely upon, can be negative in 30 to 35% of Asian type 1 diabetes at diagnosis, and I've shown the data supporting the same. Abdominal pain, steatorrhea are important history that we should take in young diabetes. They could indicate towards type 3C diabetes. If you see ketosis resistance with pancreatic calcification and you rule out other causes, this could be FCPD. If you see ketosis resistant without pancreatic calcification and a poor socioeconomic background, you could consider protein deficient diabetes or type 5 diabetes, and a detailed family history is very helpful. So the take-home points are that you have wide spectrum of etiologies under the umbrella of young onset diabetes. Type 1 diabetes is the most common. Type 2 is catching up rapidly globally, especially between the age group of 15 to 25 years. With the increasing background prevalence of obesity, the discriminatory value of BMI that we have learned goes down. Young onset type 2 diabetes has aggressive disease trajectory, accelerated vascular complications, reduced expectancy, and this disease occurs in women at a time when they are planning their family and leads to poor pregnancy outcomes. And fibrocalcific pancreatic diabetes and type 5 diabetes are something that are very unique to tropical countries, and we should not forget them despite WHO not recognizing them in the original classification. Thank you so much for your kind attention.
Thank you, sir, for that structured and impactful presentation. The dais is now open for discussion.
For that excellent presentation with multiple cases. Is there any guidelines coming in India? When do we screen our young people for diabetes?
Okay. Sir, as part of National Health Mission, you screen anybody above age of 30 years for hyperglycemia, high blood pressure. So young persons with diabetes, as I have said, they are more commonly symptomatic. So asymptomatic presentation will be unusual in young patients. So you can screen them whenever there is any symptomatic presentation. I think you don't need to screen them biochemically for an asymptomatic or incidental presentation.
Why DPP-4 inhibitors are not preferred in adolescents?
Okay. Sir, so there were 2 or 3 trials which have shown that these DPP-4 inhibitors, they don't tend to provide a durable glycemic control in adolescents with type 2 diabetes. In fact, what led to approval of SGLT2 inhibitors was the trial which looked head-on-head SGLT2 inhibitors versus DPP-4 inhibitors. So first trial was Dynamo trial, which looked at empagliflozin versus linagliptin in young onset type 2 diabetes. And the second trial was T2 trial, which looked at DAPA versus sexagliptin. And what they found was that compared to placebo, while SGLT2 inhibitors led to a significant improvement in glycemic control, the difference between placebo and DPP-4 inhibitors was not statistically significant. So that led to approval of SGLT2 inhibitors, while DPP-4, they are still not approved just because they are not believed to be efficacious, or they have not been shown in the evidence base to be efficacious in treating young type 2 diabetes, which again goes on to show that this is a more aggressive disease rather than adult onset type 2 diabetes, where you require agents that have higher efficacy for treatment.
Thank you, sir, for that excellent presentation. I thank Dr. Alpesh Goyal.
Thank you, sir.